few more people trickling in, but we have a loaded agenda this afternoon, and I'm just delighted to welcome each of you to our Medical Student Research Symposium for the class of 2025 in this season of congratulations for the class. I'd like to extend a special welcome to the students who are offered acceptances to the class of 2029 and who are here to visit. Please raise your hands so we know who you are. A warm welcome for our visiting students. As we talk about the past, you should be thinking about the future. Yeah. It was great to see so many students and faculty enjoying the poster session last hour, and especially to fill this auditorium today. It is not that often that we have the treat of having our academic community able to come together like this with representation from all four of our classes and the kind of an audience that this kind of an activity deserves. So thank you all for being here. Since the day our medical school opened its doors in 2010, research has been one of the defining strengths of our medical school. Our curriculum in research and inquiry contributes in a major way to the success of our graduates as they pursue positions in residency programs. These programs value not only the research itself, but how it prepares our graduates to apply the rigors of scientific thought to clinical practice. Our new curriculum launched last fall, and it firmly centers three medical school identities at VTC: the master adaptive learner, the system citizen, and what we've had since the very beginning, the scientist physician. These identities are at the heart of our students' journey to becoming patient-centered physicians, and we hope physician thought leaders of the future. Each identity demands that our students hone their abilities to ask just the right question. And today you will see the culmination of the students' four-year odysseys to answer their scientific questions, a path that demands resilience, is often convoluted, and always sparks more questions. By nurturing their curiosity and rigors of thought, research helps our students develop lifelong habits of practice. In their careers in residency and beyond, our graduates will have that key advantage starting here. They will have the necessary skills to critically appraise new research findings and decide which ones should drive a change in practice. Long before the guidelines are published, many years later through the consensus panels, they'll be able to get onto those best practices sooner. Congratulations are in order for each member of the class of 2025 for fulfilling the rigorous requirements of our research domain. So let's give all of them an applause right now. And I would also like to extend my heartfelt gratitude to the dream team of faculty mentors for all of your support and encouragement of our students this year. We'd like to kick off today's event by recognizing two of our mentors in particular. But before we get to that, please, a round of applause for all of our mentors. So each year, the research domain team solicits nominations from all current students and alumni for Mentors of the Year. And the 5 criteria for selection of that honor are: 1, creating an environment in which original hypothesis-driven research is effectively implemented and guided; 2, providing opportunities for professional growth; 3, challenging mentees to make original research contributions and to carry their research to completion with rigor. It's my favorite word, rigor. 4, fostering intellectual growth and technical methodological proficiency; and 5, establishing clear expectations and maintaining high standards for quality, research ethics, and work ethic. This year, we recognize a team of mentors who have together mentored or co-mentored 5 Virginia Tech Carilion School of Medicine students, each, including one who earned a Research Letter of Distinction this year and will be speaking later today. Dr. John Epling is Professor and Vice Chair for Research and Population in our Department of Family and Community Medicine, Population Health, in the Department of Family and Community Medicine of Virginia Tech Carilion School of Medicine, and was recently appointed to be the Medical Director of Ambulatory Quality and Population Health at Carilion Clinic, a quality person, Dr. Epling. Dr. Michelle Rockwell is also a quality person and also in the Department of Family and Community Medicine, where she is an assistant professor. We're thrilled that she recently joined the medical education team here at the medical school as co-director for phase 1 of HSSIP, our curriculum in health system science and interprofessional practice. The Epling and Rockwell team has been nominated enthusiastically for this award twice, each time with heartfelt letters describing in detail the team's commitment to students' development as academic researchers. Here are the words of the student nominators: Nancy Wu, Brianna Chang, Isaiah Yim, and Matthew Vinson. And I'm not sure who said which of these words. I'm just going to read them. You can imagine all of the nominators coming together with these words. With a quick wit and steadfast commitment to high-quality research, Dr. Epling is a mentor who challenges his mentees with apt questions that encourages us to critically engage with our research hypothesis, methodology, and conclusions. Dr. Michelle Rockwell, a tenacious and thoughtful mentor, goes above and beyond to push student projects forward, efficiently troubleshooting challenges that inevitably appear, and is remarkably generous with her time and expertise. Their extensive experiences in health services research solidifies them as experts in their fields, and the subsequent wealth of knowledge they have combined is a boon to us as mentees. Doctors Rockwell and Epling, please come forward to receive your awards with our gratitude and then share some of your reflections. And now if you could share some reflections on the process of being a mentor, who's coming forward? Are you doing it one at a time, together? What's the? Ukulele, that's good. Yeah, what you need. I think it should work. We checked it before.
So we had a couple of versions of these slides. So if you could ignore some errant, tenacious fast forwarding here in a second, but thank you so much, Dean Lehrman, and to our wonderful students for this award. It's actually a tremendous honor, and I think it's a reflection of the really wonderful students that we have the chance to work with, and the reflection of an extremely supportive department. There's a family community medicine VIP cheering section here today. We're really lucky. So Dr. Epling and I framed our presentations each around one word. We learned some new words today, but I get to go first, and my word was impact. I've been thinking a lot about impact recently, in particular as related to the impact that's being affected by changes in government funding and government support of research. The Agency for Healthcare Research and Quality, AHRQ, is a big funder of health services research, and they're part of the Health and Human Services reorganization that's happening right now. So I've been thinking about how that impact has been affected. I was a research fellow at AHRQ in 2020, and the culmination of that project is shown here. It was looking at the impact of AHRQ's support on primary care research. And one of the big things I took away from that is how impactful that research has been, but also how difficult it is to measure research impact. So it's sort of been on my mind ever since, thinking about what comes out of all the really hard work that we do. It was easy to measure how many papers someone published, or how many grants they got, or how many presentations they gave, and those are extremely important parts of scholarship. But it was much harder to measure the numbers 2 through 5 that you see up here. And if I really think about it, it's the number 2 and the number 5 that are the most meaningful for me as a developing researcher. It means a lot to be able to make a difference in the healthcare and health system where I work and live. That's one of my biggest drivers. It makes a big difference to me to develop infrastructure and capacity for research that wasn't there before. And a big part of that is being able to work with great learners. I think it's really hard to talk about research impact without thinking of somebody like Warren Bickel. I imagine there's some people in the room who might not know Dr. Bickel, but he was a a longtime researcher in FBRI. His main area is around addiction. He died in the fall. But on the right, you see this web of impact that Dr. Bickle has had. Those are all students he's trained or postdocs or other faculty who have worked with him. So I can't imagine having that big of a web or even a little slice of that web, but that really is the sort of thing that that drives my personal research forward. Dr. Bickle's work was in addiction and then a little bit in health behaviors. It's exciting to Dr. Epling and myself that we've been able to begin testing some delayed discounting in physicians and apply that to healthcare delivery. He'll talk more about that. So here, I hope all the M1s recognize the quality improvement framework that we talked about in class on Wednesday. We talked about one way to think about measuring quality in healthcare. It's not really meant for measuring quality in research, but I was just trying to tie everything nicely together. But we talked about structure metrics and process metrics, and it's definitely learned, but developing infrastructure for research and all the processes of research, I think as a researcher, I've really learned to enjoy that part, celebrate long submissions and little milestones, because it's a part of the whole package. But the best part is when we do have outcomes of research. And I just wanted to make sure to really highlight Nancy and Matthew's work in their research domain projects. Nancy presented just yesterday really beautifully to the Carilion-wide Social Determinants of Health and Health Equity Committee about her research project, which was evaluating a community health worker program in primary care. And Matthew's project, you'll hear more about that, but he did an RCT that actually showed a 33% decrease in high-risk medication use. And he doesn't even know this yet. We're gonna apply that video to our real ACO population moving forward. So that kind of stuff is really exciting. I didn't want to not complete our quality improvement framework, but the last type of metrics that we talked about are balance metrics. I hope you all remember that those are unintended consequences that might come out of a quality improvement initiative. So it's important to make sure that we're keeping track of that too. And just for fun, I shouldn't be sharing this, it's that bad, but just for fun, I'll share with you an unintended consequence of research that's going on right now. This is a study that I recently led with a UCLA-based team on the utilization and spending on hydroxychloroquine and ivermectin for COVID throughout the pandemic. We found there were 3 million prescriptions for ivermectin and hydroxychloroquine, totaling almost $275 million. To me, that's huge in light of knowing there's no evidence that those work for COVID and some evidence that they can cause harm. The balance metric that we should have thought of, the unintended consequence, is there's been some media that have picked it up and said things like, oh, 275 million isn't that much for those drugs because they probably work. So we can think of balance metrics, I think, in research too. So I'll hand off after just one more slide, hoping to tie together how impactful we feel primary care and population health research is within a health system and within a university. Without going through all these bullet points, in primary care, which represents 50% of the outpatient visits that happen in healthcare, primary care clinicians treat regular people with regular issues, with not regular issues. But if you want to be in a space where you're focused on preventing disease and on interacting with regular everyday people with regular everyday problems that make a real big difference in society, primary care is the type of research where that can really happen. So I feel very grateful to have that opportunity. And I will hand off and rewind the slides to my own vote for Research Mentor of the Year.
Thank you very much. So synergy is the other word we talked about. There's impact and there's synergy. And synergy is an important concept. It's where two folks that might have value in and of themselves, when combined, have potentially greater value. And that's that's what I think this collaboration, both, it was very nice to be co-honored like this, but we think there's actually, it's not just nice to be two people directing research. I actually think there's synergy there in what we're doing, and that's what I want to talk about. It may seem a little odd that we talk about synergy between MDs and PhDs, but that's what we're really trying to drive. In family medicine nationally, there is a big move to understand that MDs may not be able to carry the entire research load and drive the research agenda. And so it's very common for us to incorporate PhDs in departments in family medicine to help drive research. And I wanted, as we were setting up research in the department here, I wanted to see if we could do that. And then serendipity worked the rest of the way. We have different training. I have very little formal research training. Dr. Rockwell has very specific research training and clinical research experience. We have both progressed in our careers, and that perspective actually helps us understand how best to train trainees in research. And I think it's helped a little bit to get those different perspectives, see how a clinician that has not been through a formal MD or a PhD program or formal research training fellowship views research as opposed to a PhD might. Our respective specialties of family medicine and nutrition are very complementary for that, and in this case, synergistic. We have worked on projects that look at nutrition, lifestyle medicine, and because family medicine is such an important part, prevention and nutrition are such an important part of primary care and family medicine, there's obvious synergy there. Our ideas and energy and approach are very different. I have somewhat constrained amount of time because of other hats I wear. Dr. Rockwell is devoted to advancing our research mission. We have different experiences, different things that have worked, and combining those and talking about those together has really helped a lot in both directions. We both have at our core a dedication to teaching and mentoring. I've often said to others that I think I'm at base a teacher. Sometimes that also gets called pedantic, but anyway, at base a teacher, even in medicine and all the stuff I do. So it's very important to me. I know it's important to Dr. Rockwell. And so we use that as our linchpin here. It's not all sunny and roses. We have very different approaches, for instance, for having our pictures taken. And you saw that sort of demonstrated. She is very professional and pleasant, and I am mostly surly and unapproachable. But that's, that sort of works for us. That's how that happens. A physician lead and a director have different responsibilities in the department. When we talked about Dr. Rockwell joining the department, it was as at least a significant portion of her time would be as an independent investigator. So she is not tasked with doing my research for me. I never felt like that would work completely well. And I think we both benefit from the fact that we operate more as colleagues and less as a physician lead and director. We're both very interested in data science, and you heard this idea of delay discounting in LVC over time, and LVC is low value care. I'll get to that in a bit. Over time, our research interests have really sort of merged, and we've brought different things that we're interested in to bear to new and different problems. So I had a history of doing some vignette research. We've brought that in and done that in several studies to try to replicate physician decision-making. And in that particular case, we've tried to look at the impact of delay discounting on clinician decision-making, and we'll be hopefully publishing that shortly. But we also looked at a term we call sludge, which incorporates a lot of administrative burden that gets in the way of things. We looked at colorectal cancer and found that there was a lot of delay. Delay contributed badly to sludge in the field of colorectal cancer. So we're looking at maybe a delay discounting intervention to help patients better tolerate the delays that are sometimes inevitable in this. So in really working with each of these concepts and working together on each of these, we are gradually honing in on several research foci. Now, I'm the first one to say that primary care researchers are not focused. I wouldn't do well as a traditional NIH researcher. That's not who I am. But I think that gradually getting some focus and applying methodologies back and forth, I think it really helped us. The synergy of family medicine, which is a very clinically focused, patient-focused endeavor, and population health, which is about lots and lots of patients and what can help people in broad scope here is an interesting synergy. It's something that I and those of you that have been taught by Dr. Morrow have worked on during our careers, how to integrate population health, public health, and individual clinical care, and how can each benefit from each. Evidence-based medicine grew out of the idea of applying population health and public health terms and interests and concepts to individual clinical care. So this is a rich field of synergy for actually both of us. We have a wide lens. We have studied molecules like COVID-19 and their ability to detect them, all the way up to large trends in ivermectin for COVID and other medications. So we really have a pretty wide lens, but from molecules to management. I said I was trying to think of terms that were alliterative, but so forgive me for that. The primary health and population health model is synergistic in that we really dive into implementation research, finding out what works in labs and in clinical research units, and bringing that into the population and into practice is one of our main focus. There's lots unexplored in both primary care and population health, and certainly in the intersection of those two. So using qualitative research and mixed methods is part of what we do to explore that. And then a lot of the stuff that we do is social and behavioral, getting people to act differently, think differently, have a different lifestyle. Lots of our focus there. We try to keep our group, we call our family medicine research group. It's not so much a lab. I think of lab and I think of tool benches and pipettes and those type of things. Our group has a diversity of learners from medical school, population health, residents, faculty. We try to bring everybody in and cross-pollinate ideas and levels of experience in our research. Project types, again, methodologies vary: qualitative, quantitative, data science, clinical trial, and even seeing if we can meld some of those and use qualitative and data science together, those type of things. And lots of varying content, but as I said before, generally overlapping themes, so that we're working toward a set of methodologies and ideas. We were first introduced to each other over vitamin D, sort of. I had done some work in the emerging lack of rigorous practice around vitamin D prescription that health professionals gotten into. Dr. Rockwell was coming from an area of vitamin D nutrition research, looking to get into health services. We met, hit it off, found that we had common interests, and decided to start working together. And it's been a very fruitful partnership. The idea of low value care is delivering care that is neither helpful, not helpful, or potentially harmful. And our research has really coalesced around that idea. The evidence-based medicine is where I came from, and mostly arguments about evidence-based medicine nowadays are not so much about what we know we should do. Those have been institutionalized a little bit, giving aspirin for heart disease, those type of things, pretty well ensconced. It's mostly about knowing what we should not do, and how do we get rid of stuff that doesn't help. And that comes into that low value care causes waste, burden, administrative friction. There are all sorts of terms for it. The C-suite at Carillion is now studying a book that talks about this very concept. They call it friction, the friction project, I think. So it's an important sticky concept that I think we are actively studying. What the EMR folks talk about, getting rid of stupid stuff. It's the same sort of concept. What are we doing that we shouldn't be doing? And how do we do less of the stuff that we shouldn't be and more of the stuff that we can? With a promise that if we clear the decks of the stupid stuff, that we can do more of that high value patient-oriented care. Again, none of this would be important at all unless we had our students to talk about and to work with. And so I want to really thank the students for nominating us for this award. We'd love to have more students as we go. We look to continue to do this. And thanks very much.
I took a lot of my inspiration from my own grandfather, who I can remember taking BC powders multiple times a day. And I even went to one of his doctor's appointment one time, and the doctor asked, "Are you taking any over-the-counter medications?" And he said, "Oh, no, I'm not taking anything."
Non-steroidal anti-inflammatory drugs, or NSAIDs, can be very helpful medications, but may also have harmful side effects.
Matthew was interested in understanding what could influence patient behavior around over-the-counter NSAID use.
That's a great question. So when we look at the medication and look at
My project was looking at ways that we could very quickly and efficiently address this issue, where we were educating the population on some of the harmful and potential side effects of over-the-counter NSAIDs. So we developed a video to educate, but also to motivate this population to decrease their use.
Patients said things to us like, I had no idea that this was a high-risk medication, or I take 20 or 30 Advil tablets a day for whatever type of pain. In Matthew's study, we observed that this simple intervention reduced high-risk NSAID use by 10 days per month. A lot, a very big behavior change difference with a very small intervention.
Thank you so much, Doctor, for your help.
Matthew really wanted to do an intervention that really impacted real people. And I think his commitment in that respect was really thoughtful. He really wanted to do something that had a good impact.
In our profession, we have a blessing to be able to educate and treat and serve our communities. But more than anything, I really want our patient population to feel empowered to care for themselves. Working with my two mentors was phenomenal. They really took an interest in us personally, not only wanting to see my research succeed, but wanting to see my career succeed.
It's very fun to be able to work with John on research projects exactly like Matthew's, because it plays to our strengths. Him as a clinician and with lots of experience with evidence-based medicine, combined with my experience as a health services researcher, really paired well for a study like Matthew's.
I think we have a great model for research collaboration between Dr. Rockwell and myself. MDs and PhDs can and should work together to advance the research mission. We are lucky to have stumbled upon each other, I think, to work together and produce the research that we do.
They go above and beyond, and every step of the way, trying to make sure that we learn the skills that we would like to learn.
He put in the work. He really worked really hard at making this a successful project. So it was really a pleasure to watch and work on with him.
They absolutely deserve to be Research Mentors of the Year. There's no way I would have been able to do this project without them.
Congratulations again. Now we're going to go ahead and start our formal program. So we're going to hear for the next couple of sessions from our letter of distinction winners from our class of 2025. These talks are going to be about 5 minutes long, and then we're going to have a few minutes for questions afterwards. There's a couple of microphones on either side, and we're going to be monitoring via YouTube. So Dr. Nikki Worthington, our Director of Clinical Research Education, will be helping with that phase of this. So be sure to have your questions ready. We're going to hear right now from our first presenter, who is indeed Matthew Vinson. We have a few comments from our mentors for our introductions this year, and Dr. Rockwell actually shared with us that Matthew was unenthusiastic about research from the start, telling her, I assure you I'll work hard on my med school project, but I don't like research, and I don't want to be a researcher after this. Despite this, Matthew dove into his project with passion, going so far as to actually break Carillion's email server for an afternoon as part of his RCT. Dr. Rockwell says, I believe Matthew's composure, critical thinking, clear communication, and genuine empathy made him an excellent researcher, even if he didn't like it. He will move forward as a highly successful physician scientist. So we're going to bring Matthew up here to tell us a little bit about his efforts to reduce potentially harmful regular over-the-counter NSAID use via a novel, brief, patient-facing educational video.
Thank you for that. You're right. I can't say that I've grown to love research, but it's been a lot more pleasant than I thought it was going to be. So hello, my name is Matthew Vinson. Throughout my project, we analyzed the effectiveness of an educational video in reducing what we call high risk over-the-counter NSAID use, and I hope I can describe what that is here briefly. So NSAIDs are effective at treating pain and inflammation, but like every other kind of medication, they can come with the possibility of adverse effects. Because of these risks, multiple professional organizations have released guidelines stating that you should not take regular or long-term doses of NSAIDs, particularly in patients with chronic kidney disease, heart failure, and hypertension. Despite this, there's an alarmingly high prevalence of this type of medication behavior in this population, which makes a large, substantial population of our country. Our group looked at did a scoping review to look at some previous interventions and found one glaring limitation in the prior interventions, mainly that they failed to focus on over-the-counter NSAIDs. A lot of times they focus on prescription only. So our objective was to evaluate the effectiveness of a brief, patient-focused educational video in reducing high-risk regular over-the-counter NSAIDs. We wrote our script, filmed our video using what's known as the COM-B model. This is a behavioral change model that takes capability, which is the knowledge and skills, which was prior really the only focus on previous interventions, but also weaves in the importance and influence of opportunity. Do people actually have the chance to make a change? And motivation, do they even desire to make that change? This became the foundation of our video in our study. We conducted a survey-based randomized control trial where we screened, initially we sent it to 98,000 participants, which is what broke the email server, asking them how frequently they were taking over-the-counter NSAIDs in four different categories. Those that reported as taking any dose or type of NSAID 3 or more days per week for the last 3 months or more qualified or met criteria as a regular over-the-counter NSAID user and were invited to participate. They were then randomized either to view our video or, just as small as this, to review the FDA warning label that comes on the back of the packages that no one can read. Both groups then answered questions beforehand to get a baseline understanding, immediately after to see immediate impacts, and then 4 weeks later to see any long-lasting impacts. We ultimately had 3,233 participants that screened for our study, with 917 following through with the study after exclusion. We ultimately had 425 that completed the 4-week follow-up as well. I want to stop here for a second to mention that of those that screened for our study, 45% of these high-risk users reported self-identified as regular over-the-counter NSAID users, pointing not only just to the prevalence within our population, but the importance of the study. My first primary outcome that I'll cover is what we call intent to decrease over-the-counter NSAIDs. I know it's a mouthful, but the way we analyze this is by using the contemplation ladder that you can see here. This is a validated tool that's been used to assess changes in behavior, starting at lower, what we call the rungs, lower levels on the ladder, where no one's thinking about making a change in their behavior. And as you climb up this ladder, it's more and more thoughts or actual actions to changing that behavior. This has been found to correlate well with the stages of change model as well. So what we found is that from that pre to post kind of time point, our video had a greater impact. It had a much larger increase in that change from pre to post. And you can see in this graph that both groups continue to increase. Although we lose the statistical significance, we're still seeing the awareness of bringing this to people has a great impact on their medication changes and behaviors. I think this is the more powerful point, and what my mentor mentioned earlier. Although we have no statistical difference between the groups, both groups have a huge clinical difference here, where they decrease by approximately 33% of their actual use, or at least self-reported use. That means they're taking 10 doses less a month. But what I really think is cool is that despite taking less pain medication, no increases of pain were noticed. So they're not having an increase in pain by decreasing their pain medication. I won't talk about this too much, but we did look at the individual components of that COM-B model and ran moderator analysis and found that both opportunity and motivation have a positive impact on how our intervention worked. It's not just the capability component, but we need to address this motivation and opportunity for our patients. So the implications of my study was that we have a high prevalence of this high-risk use, and this brief patient-centered education video shows promise for improving population health related to over-the-counter NSAID use. I'm saying thank you for everyone that's here, all the participants that I had in our study, and the amazing team to make our video work. If you want to see the video, that's the QR code for it. But does anyone have any questions?
All right, we're going to open the floor to questions.
Thanks. That's a lot to present in just a few minutes. I appreciate you using a conceptual model and looking at this the way you did. You ran into a pretty common issue that occurs, the post-randomization, loss to follow-up. And I just wanted to know whether you were able to measure any of the differences between those that were able to do the post assessment and those who were not, in terms of how that might have biased your results.
Yeah, we didn't run that analysis, but the graph that I showed was actually where you see the 3 time points. I can go back to it. This was only for the 445 that completed the study, and this as well. So we really only showed the data for those that completed all 3 aspects. What we saw, and I don't have it presented here, is that with that initial 917 participants, there was actually a greater impact for those that started at a lower baseline intent. It was much larger of a gap than we show here. It was closer to 2 rungs as opposed to 1.5. Now, we didn't run any analysis to see what kind of the correlation or causation of that was, though.
As it moves to publication, it's something you might want to talk about in the limitations paragraph of an otherwise really exciting study.
Yeah, thank you.
Question for you. So if you could keep that graph up for me, that'd be great. So did you at all measure whether or not patients were looking back at either their instructions on the back of the pill bottle or rewatching the video? Was that data recorded? And do you think that's something that is going to show a statistical difference or explain some of your statistical difference and why you've lost it at that 4-week follow-up?
Yeah, no, great question. No, we didn't have the ability to track whether or not they were able to go back. They didn't have access to go back, but I think that's a really important point because for our control group, they saw the FDA warning label. So every single time they thought about going to that product, they picked up the bottle. Maybe they had that reinforcement of, oh, that's right, these could potentially be harmful, leading to that increase in kind of steep increase in slope you see with the control group, as opposed to the video group couldn't go back and rewatch that. Maybe they just had to remember it themselves.
So as your mentor said that this is going to start to get implemented into the ACO kind of organization for Carillion, is that something that's going to be easily accessible for patients to rewatch the video and kind of bring that back to their memory of, hey, I probably shouldn't be using this NSAID for my OA? Is this something that I should actually be trying to talk to my provider about, either long-term care for me or what other options they might have?
Yeah, I'm not quite sure how they're going to implement this, but I hope so, because that was kind of my whole I guess, goal of that video was to empower patients to ask the questions, to kind of put it in their lap, of take control of their own healthcare. So I hope so. That's all I can answer with that.
Well, thank you.
Great question. Yeah.
Well, thank you.
If you have the QR code, you can watch as many times as you want.
All right.
Thank you.
Our next presenter is Farwa Iqbal. She worked with Dr. Scott Johnstone from FBRI's Center for Vascular and Heart Research. Dr. Johnstone shares that Farwa has been an immensely positive force in his lab, independently troubleshooting issues, communicating with researchers at other institutions, and providing data used in grant submissions and talks that will eventually form part of a publication. Beyond her academic accomplishments, Farwa is always positive, a team player, and an active lab member who cares deeply for her colleagues. Now we're going to hear about her characterization of macrophage and smooth muscle cell communication in neointima formation. Farwa.
Hi, everyone. Thank you so much for that introduction. So happy to be here. So we're going to just jump right into it. Our lab basically focuses on understanding the mechanisms of vascular disease. This image is from my recent publication where we showed human saphenous vein grafts that were used for bypass that were stored in human patient blood compared to saline control groups actually had better endothelial coverage and integrity, with the hopes that we have decreased graft failure rates at Carillion Clinic. So today I'll be talking a little bit about understanding the crosstalk between the immune cells and smooth muscle cells in vascular disease. So we all know of someone who has gotten a stent to open up a blood vessel after a blockage. Approximately 20 to 30% of patients undergo reblockage, or what we call restenosis, within 6 to 9 months. And initially, or the reason why is naturally when we deploy the stent, it injures the vessel. But our lab focuses on understanding how does this happen and what can we do to prevent it from happening. And I just want to just mention that the blockage we refer to as neointima. I'll be saying that a lot. Okay. So just a quick overview about the normal architecture of the blood vessel. Here we have the lumen where the blood flows. We have the tunica intima, which is comprised of the single cell endothelial cells, which sits on this thick connective tissue, which we call the intact internal elastic lamina, the IEL. And then we have the tunica media, which is comprised of the smooth muscle cells, and then the adventitia. So in our lab, we use a mouse model of neointima, where essentially what we do is we ligate or we tie off the common carotid artery. And when we section that artery, this is what it looks like, where you can appreciate there's significant cell proliferation that's going on here, pretty much decreasing that size of the vessel lumen. And our lab has come up with a way where we can pretty much cut that vessel open, so we can actually see the neointima in its entirety. This is where we've ligated it. This is that aggressive proliferation I was talking about. And if that's the lumen, you can see that we have pretty much occlusion or blockage there. And when we stain the same vessels looking at macrophages, we see that the macrophage is home to those regions of injury specifically and not to non-injured sites. So the question is, we know that macrophage is home to areas of vascular injury, but how do macrophages and smooth muscle cells together lead to neointima formation? So at FBRI, we have really cool gadgets and microscopes that we can use. And so this is a section of the blood vessel where we can see really high resolution. Just to orient everyone, this is the blood vessel lumen. That's where the blood flows. These are the macrophages, the endothelial cells, that the connective tissue I was talking about, and then the smooth muscle cells here. If you can appreciate, there's a break in the vessel wall here. And what I wanted to do was to model the connections between the macrophages and smooth muscle cells. So using another really cool program, the Mira software, we're able to, I wanted to show that, do the cells actually talk to each other? And so just to orient everyone, the purple or pink is the macrophages. This is the thick IEL, and these are the smooth muscle cells. And here we see, if I can play this video. Maybe I can press no. Are you able to play it? Yeah, thank you so much. So we see that the macrophage create these holes in the IEL and extend their membrane projections, and then essentially forming close contact with the smooth muscle cells, which are here in blue. So this was really exciting because we've actually never been able to see this before in the literature. So for me, the next question was, okay, that's really cool, right? Like we can see that, but are there actually connections and channels that are forming between both cells? So when staining for contact channels, specifically gap junctions, connexin 43, we actually see that at the breaks, the macrophages and smooth muscle cells form that contact. And again, that's really cool, but are the cells actually talking to each other or not? And so we pre-labeled the macrophages with a dye and co-cultured the cells together. And after a few hours, we saw that the smooth muscle cells significantly took up that dye. So they are talking to each other. And then the next question was, well, if we culture the cells together, do the macrophages actually contribute to smooth muscle proliferation or not? So using a proliferation assay, we can see that the smooth muscle cells that actually increase in proliferation when co-cultured with macrophages, the pink signal here. And then lastly, which is my favorite, what is happening at the gene level, right? So what we did was we processed the smooth muscle cells for RNA sequencing, and we see that the transcripts that are involved with muscle cell proliferation and immune cell activation are significantly increased with macrophages. and they decrease the transcripts that are associated with muscle cell organization and contraction. And these are the genes that are normally expressed by healthy smooth muscle cells in a healthy vessel. So altogether, we've shown really for the first time that both smooth muscle cells and specifically macrophages contribute to nia intima. The mechanisms, we're still working on identifying them, but the macrophages create breaks in the IEL, form contact with smooth muscle cells that lead to aggressive proliferation. And for me, as a future clinician, a surgeon scientist, hopefully, the goal is to create new and better drugs that we can coat the stents with. Because right now we have stuff, but they're anti-cancer drugs, which I feel like for the vessels are probably not the right drugs that we have, but that's the best that we have. So this is a great opportunity for a new drug development. And with that, I'd love to thank my PI, Dr. John Stone, Mark, and Megan, who've been really helpful during my time here. And if you have any specific questions about really the gritty parts of the experiments, please stop by at my poster today. Thank you.
Thank you so much.
Thank you.
Any questions?
To put some clinical context, obviously one of the big things we wrestle with is this restenosis once we do a vascular procedure.
Right.
And so addressing macrophages as a potential etiology is helpful. We typically will throw antiplatelets, aspirin, Plavix, clopidogrel,
Right.
would be the appropriate generic term. So I was wondering, you mentioned, targeting specific entities, but we do have some in existence, right? We do have nanoparticles, monoclonal antibodies, TNF, so we do have things that will address immunomodulating agents with macrophages specifically. And I don't know if there's any literature out there that assesses the use of those agents and the applicability based on what you demonstrated here.
That's a great question. I did have that on my conclusion slide. I just thought it'd be overwhelming, so I removed it. So there's a lot of research going on in immunotherapy and how we can alter that polarization. What I didn't show is just the other side of the coin is macrophages. And we initially thought that, there's M1 and M2 pro-inflammatory, anti-inflammatory, but after single cell sequencing has come out, we realized that there's a very heterogeneous populations of macrophages. So now we're going back to the bench side and looking at ways that we can alter that polarization and I guess, form new immunotherapy because that's one of the big sides of this is inflammation. The moment we injure those endothelial cells, they secrete all these things that, hey, immune cells, we have injury, come here. So that if that's the first step, I think that would be the first ideal target to prevent that inflammatory response. So we don't have really good therapy right now that we're actually using in the clinic or in the ORs, but that's where a big bulk of the funding and research is contributed to. Thank you.
Hi, I have a very brief comment, not a question. Comment is a very important study, actually a beautiful and important step. And I think it's a great example. We often don't appreciate how basic scientific understanding of a mechanism may actually change people's lives in terms of suffering and health. This is one that will do it. Good work.
Thank you, Dr. Friedlander. Thank you so much, everyone.
All right, our next presenter is going to be Monica Gerber. She actually worked with some of our mentors up at Children's National Hospital, Dr. Catherine Bollard, Dr. Amy Hunt, and Dr. Holly Meany. Monica's mentors share that she's shown enthusiasm and drive, diving into a busy lab, ready to learn new skills and working easily with the team. She made thoughtful additions to the team's T-cell assays and showed a great understanding of the context of translational research, and as well demonstrated a compassion for patients on the clinical side. So now we're going to hear a little bit about how she characterized the expansion of tumor-associated antigen T cells for next-generation T-cell immunotherapy targeting pediatric solid tumors. Monica.
Hello, everybody. Thank you all for coming and listening to my very brief presentation on characterizing the expansion of tumor-associated antigen T cells for next-generation T cell immunotherapy targeting pediatric solid tumors. So I'm going to start out by talking about why we're targeting pediatric solid tumors and why rhabdomyosarcoma and Ewing sarcoma in particular. Both of these types of cancers have poor prognoses, especially when they are relapsed or refractory to their standard of care treatment, indicating a need for some new novel treatment ideas. Some of those have been targeted therapies, immunotherapies, all that kind of thing. And for this project, we incorporated 2 different tumor antigens, preferentially expressed antigen for melanoma, it stands for PRAME, and B7H3. Into this project. And then we also wanted to manipulate the tumor microenvironment because with similar cellular therapies like CAR T cell therapy, the tumor microenvironment is quite aggressive and makes the therapies less effective. So we'll be looking at IL-8 and TGF-beta as well. Here's a pretty picture about how we're going to combine all of these things into a next generation cellular immunotherapy. We start with peripheral blood mononuclear cells. For this part of the project, it's been from healthy donors, but in the future, it'll be from the cancer patients themselves. And then we generate PRAME-specific TAA-T cells from those cells and then genetically engineer them to express one or multiple of the following constructs: a TGF-beta dominant negative receptor that stops the TGF-beta signaling, a B7H3 chimeric antigen receptor, that's your CAR receptor, that activates upon exposure to B7H3, and an IL-8 sync receptor, which helps hone the cells into or close proximity of the cancer. It is our hope that we'll be able to combine all of these in the most effective way to treat patients with rhabdomyosarcoma and Ewing sarcoma. So how did we characterize this particular therapy? We started with 2 populations of cells. The PRAME-pulsed PHA blasts are our antigen-presenting cells, and then the PRAME-specific TAA-T cells. We looked at both of those with multi-channel flow cytometry to look at the molecular expression of a panel of markers that we developed. And then we also looked at the flow cytometry before and after we genetically engineered them with the constructs that we talked about on the previous slide. Taking a look at the results, we can see that the antigen-presenting cells and the tumor-associated antigen T cell products express complementary markers that correlate to a diverse and activated phenotype. The antigen-presenting cells express both classes of MHC, so you're going to see cytotoxic and helper T cells in the population that we're treating with. And the product cells also express multiple co-stimulatory domains that correlate to activation against their target tumors. Taking a look at the product specifically, there's also potential for multimodal therapy. We incorporated a couple of immunotherapy markers into our panel of expression. PD-L1 has been shown to be positive in previous iterations of this type of product. We have yet to see that in our cells now, but we're going to keep looking for it. And then CX3CR1 has been shown in previous studies to be a biomarker for efficacy of chemoimmunotherapy. Based on shown by the positivity here in our products, it could be a potential biomarker for immunotherapy here as well. When we look at the genetic engineering, when we transduced the PRAME TAA-T products with the dominant negative receptor, we see consistency in the expression of the molecular panel that we looked at, indicating that their function is not altered by our genetic engineering and the T cells are still able to be effective and target their tumors. Looking at the other 2 constructs, the CAR and the IL-8 sync receptor show similar results with consistent expression when transduced with not just 1, but also 2 of the constructs, with the exception of CD40 ligand, which had an increase in expression with the B7H3 CAR. Next steps are going to be transducing multiple into this PRAME specific, and then looking at what combination is the most effective and safe for patient treatment. So it's a lot of jargon, a lot of words, but it's a lot of promising preclinical data. And we have a phase 1 clinical trial that is upcoming. So we're excited and hope that we're going to have some promising clinical outcomes. Thanks for listening.
Thank you, Monica.
Yeah.
Do we have any questions for Monica?
Not.
You did such a good job
Cool.
explaining it.
If you have any questions, I'll be in my poster after this session as well. Thank you.
Next, we have Brian Hansen. Brian was mentored by Dr. John Sloboda and Peter Apel from the Department of Orthopedics. Brian's research team shares that he's an exceptional researcher whose dedication is evident through the 4 publications he's authored while here at VTCSOM. Brian served as a leader of our Musculoskeletal Educational Research Center that comes out of the Department of Orthopedics, where he demonstrated remarkable leadership qualities, guiding his peers with passion and commitment while fostering a scientific mindset. His ability to encourage critical thinking and collaboration sets him apart as an inspiring role model in our academic community. So Brian's going to tell us a little bit about some modifications he and his team made to the Geriatric Nutritional Risk Index that helps us predict complications after total joint arthroplasty. Brian.
Hello, everyone. My name is Brian Hansen, and like mentioned earlier, I'm going to be presenting on the modifications we made to the Geriatric Nutritional Risk Index and how we can predict outcomes after total joint arthroplasty. So starting out, what is total joint arthroplasty? This includes total hip arthroplasty as well as total knee arthroplasty. And this is where damaged bone and cartilage is removed, replaced with a prosthesis and bearing surface. And it's indicated in patients with end-stage osteoarthritis and who have failed conservative treatment. And about 3 million TJAs are performed each year. And it's one of the most consistently successful surgeries in orthopedics. However, there is a rare but devastating outcome called prosthetic joint infection, or PJI. These are inherently difficult to treat, require revision surgeries, and patients have long-term sequelae associated with it. And it's estimated to cost the healthcare system $2.8 billion by 2030. So there's been multiple efforts to try to avoid the risk of PJI. And that includes preoperative, perioperative exposures. So we've given IV antibiotics and implement aseptic technique. And then we've also looked at modifiable risk factors. And we're all familiar with these, like diabetes, smoking, and obesity. One that doesn't get a lot of attention, though, is malnutrition. Of course, we all know how to treat malnutrition. That's with nutritional supplementation. But how are we measuring nutrition? And so Aspen, which is the authority on nutrition in the United States, says there's no gold standard. And that's because it's not uniformly applicable to all clinical populations. And that's has created many screening tools. And right now, there's no consensus in orthopedic literature on what we should use for total joint patients. And so clinicians tend to lean towards biomarkers because, and I've listed some here on the right, because they're more rapid and less subjective. And in a 2017 meta-analysis, it showed that these predicted malnutrition regardless of inflammatory state, and that included albumin, prealbumin, and total lymphocyte count. And knowing that, we can combine these into one metric called a nutritional index. And there's been many that have been developed, and I'm going to show you some in a second. So here are a couple, OPNI, MI, and then more importantly, the Geriatric Nutritional Risk Index. If you note, this also implements a patient's ideal weight percent. And it fails to capture patients within the obesity paradox. It only considers patients that are in the low BMI category. And that's problematic, right? Because the obesity paradox is when patients are overweight and protein calorie malnourished and often overlooked. In the JAMA article right here that I've listed right above this, you can see that when it comes to all-cause mortality, there's an increase in low BMI patients as well as high BMI patients. And since obesity rates are on the rise, and we know that 30% of patients that are overweight are also malnourished, we wanted to capture these individuals. So we developed the Modified Geriatric Nutritional Index, or MGNRI. We made modifications so that it's the difference from the ideal weight percent, and so that patients that are overweight and protein calorie malnourished are also captured. So now that we've developed this index, we want to test it and see how it performs against other nutritional indexes and see if it can predict outcomes. So what we did was a retrospective cohort study with the index event being a primary total joint arthroplasty. And then we collected preoperative measures of albumin, prealbumin, and total lymphocyte count. And our outcome measures, as I mentioned earlier, was PJI, wound complications, return to the OR, or readmission. So once we collected our data, we wanted to see how they perform against other nutritional indices. And so as you can see here, we had 1,500 patients enrolled, and MGNRI had the greatest area under the curve. showing that it outperformed all the other tests that we put it up against. Additionally, once we figured out that it was performing well, we wanted to figure out what cut point should we use as a clinician? What should we tell our patients? Hey, if you're below this, you're at risk. And so we did Uden's index, and we found that 92.8 was the cutoff point. And so using that, we separated our cohorts into two cohorts here. And then the low MGNRI ones are the ones that are identified at risk. Also, I just wanted to point out, we identified some confounding variables that I'll talk about in a second, and we used a regression analysis to control for those. So this is where the money is. We were looking at the complication rates for patients that are low MGNRI. And what we found that they were significantly higher for PJI, wound complications, readmission, and reoperation if they were considered low MGNRI. So next, we wanted to control for these confounding variables. And so we did a multivariable logistic regression for that. And what we found was that the adjusted odds ratio for getting a PJI, if you were low MGNRI, was 8. So that's to say, if we control for all their confounders, your odds of getting a PJI are 8 times higher than a normal patient. So what does this mean? Why does this matter? So MGNRI is an easy to calculate index, and we made a free calculator. You can scan the QR code and it'll take you to a calculator and on our website, and you can just plug in the data. And it requires no change in practice. We're already collecting albumin and weight preoperatively. And it outperformed all the other nutritional indices. And we also know to use the 92.8 cut point when we're looking at patients' preoperative risk. So future directions for this research is, what's the best nutritional intervention? Now that we've identified these patients that are at risk, what can we do to help them? And how long do we need to help them? And then if a patient's low and then we move them to normal, is their risk the same as a normal patient? So these are my acknowledgements, and I'll take any questions.
Okay, Brian. Start with Dr. Lehrman over here.
Well done. A very exciting study. You relied on a historic database, did a retrospective study. And so my question is, how are you thinking about the, where you take this next in terms of showing a similar performance of this new index in a different population?
Yeah, so it's kind of, it's hard because like I said, Aspen, they say that, you know, there's no gold standard because you have to consider all clinical populations separately. And so we were looking at total joint arthroplasty patients, but that's not to say we can't implement this same formula in a different population and see how it performs. So I think the impact here is that you can use this formula, just plug it in, and then see how it performs for other patients. And then moving forward, we need to see what we can do once we've identified these patients that are at risk and help them.
So the role to tool development like this will often have a validating other next study in which you take the same idea into a different population, either in the same institution or ideally in a different one, and it shows the same performance. The other issue I want to mention is that you identify these important confounders that really change the way the index works. Are you considering adding that into your app that you have for prediction?
Absolutely. So one of the confounding variables was BMI, and that is accounted for via the ideal weight percent. Other ones like age would be an interesting one to also implement, and then comorbidities as well. So it's hard to do that. And the answer is yes, absolutely. And maybe a future direction for another study.
Thank you.
Mm-hmm.
Hi, over here. Nice work, nice study. Did your team discuss at all how you might modify or reanalyze the data instead of a singular cutoff in terms of risk to make a sliding scale, if you will, of risk?
Absolutely. And it's funny you mentioned that. We discussed that ad nauseum. And we decided to do the one cut point for ease, essentially. We wanted to make it so that clinicians could walk in the door and be like, all right, do I need to consult a dietitian before this patient gets a total joint arthroplasty? The answer to your question is, I think it would be better if we stratified patients, low, medium, high risk.
I had a quick question in terms of the malnutrition criteria, looking at it was albumin, and then total lymphocyte count. Now, the TLC, how do you believe that could potentially be a confounding factor if that is an element contributing to malnutrition? And then if you're comparing the result to prosthetic joint infections, do you see a potential correlation there or a potential confounding factor?
Yeah, absolutely. And so these are pre-operative assessments. So the idea is that, we're looking at the risk beforehand. I agree that if a patient has a PGI, no doubt TLC is going to be through the roof. And so the idea is that by using albumin, the half-life 2 weeks, pre-albumin 1 week, TLC 3 days. And so you're kind of capturing nutrition at different time points and it gives a better picture. But you're absolutely right. It could be a confounding variable if they're already in an infectious state.
Hey, I was just curious about the decision-making changes that occur when a patient does come back at a higher risk. What sorts of change, like do they have surgery still, or do they have different sorts of interventions that they can use to prevent complications?
Absolutely. And that is provider dependent. I know that the PIs on this study, Dr. Sloboda and Dr. Drados, have already implemented this into their clinical practice. And so if a patient's at risk, they're getting a dietitian referral. They're going to be put on Ensure for protein calorie malnutrition. And so they're looking at that. So they identify the risk. And what we'd love to see is at Carillion is everybody implementing this because it's super easy. You just plug it in. And, if you consider a normal risk is 2% for PGI, 8 times that, that's horrible. 16% risk for getting a PGI. So it's super easy, and I think we should all use it.
Thanks.
All right, our next speaker is Sarah Kramer, who worked with Dr. Jenny Munson from FBRI's Cancer Research Center. Dr. Munson shares that Sarah was her first medical student, and she's been a fantastic member of the lab, taking on a new project in pediatric glioma and running with it. She always worked hard, stayed organized, and kept her enthusiasm for helping kids first and foremost in her work. So now we're going to hear Sarah tell us a little bit about characterizing the tumor microenvironment in diffuse midline glioma for 3D in vitro model building.
Hello, everyone. My name is Sarah, and today I'll be talking about my research project, characterization of the tumor microenvironment in diffuse midline glioma for 3D in vitro model building. So first, I'd like to start off by talking about diffuse midline glioma, or DMG, and what exactly this is. So this is a very aggressive pediatric brainstem cancer that affects children mainly from the ages of 5 to 10 years old. Here we see an MRI image of the tumor, and it's circled in red here. The median survival is only about 9 months for these children, and the 5-year survival rate is only 2%. There's many treatment complications and treatment difficulties. Surgical resection of these tumors is not an option due to the location of the tumor, and radiation therapy is used, but it's really a palliative treatment that does not cure these children. There have been a handful of studies looking at the composition of DMG tumors and the microenvironment surrounding these tumors, but these mainly focus on the immune microenvironment for potential immunotherapy targets, and it's unclear if there really is a comprehensive characterization of DMG tumors, specifically for the purpose of 3D in vitro model building. So what exactly are we asking in this study? The research questions that I asked is, what is the overall tumor composition of DMG? What does the tumor look like in these patients? How does the composition of DMG tumors differ between patients? Do we see differences between patients? And then do we see differences between the primary tumor site, a metastatic site, and the normal tissue within a single patient? So what types of samples did we use and how did we obtain these? So we partnered with Children's National and their biorepository bank. So all of these are autopsy samples from patients who passed away from DMG. We initially had 10 patients and they had primary tumor samples here. We then got an additional 10 patients that had paired samples, that each patient had a primary tumor, a metastatic site, and a normal tissue. So in total, we had 20 primary tumors that we analyzed. So how did we analyze these patient samples? So we used immunohistochemistry staining to analyze these samples. So we got FFPE blocks, I sectioned and mounted these. I then stained them for a variety of different cell types, including astrocytes, microglia, neurons, tumors, and blood vessels. And from there, we used high-power imaging technology to take images of these samples and then used an automated computer software program to help count and analyze these images. So what does our patient population look like? So when we look at the 20 patients that we included, what do they look like? Here's an overview, and really I want to highlight the age of these children. So the youngest we had was 2, the oldest we had was 13. The median age is 5.5 years, which is similar to the broader population of patients. Overall survival ranged from 2 months to 38 months, with a median overall survival of 9.5 months. This just really shows that our patient population, our sample population, is representative of the wider patient population as a whole. And so then specifically with imaging, what did we see with our imaging? And so I have some pretty pictures for you guys. On the left, we have microglia and astrocytes. In the middle, we have neurons. And then on the right, we have DMG tumors. These are representative images of the wider study and what were used to calculate and count all of the different cells within these tissue samples. So how do these different cell types compare across patients? So here on the left, you can see a graph that shows the proportion of total cells. So we count the number of astrocytes within a sample and compare it to the total number of cells within that sample. We do that for microglia, neurons, and tumor cells within each primary tumor site. So as you can see on our graph, astrocytes and microglia occur in similar proportions across patients. There's no real statistical difference between those two cell types. Neurons occur in significantly smaller proportions compared to the other cell types across patients. And then how do these cell types compare across sample sites? So when looking within 10 patients, how do these cell types differ among your normal tissue, your metastatic tissue, and your tumor, your primary tumor? So astrocyte proportions over here on the left do not differ significantly across your sample sites. Microglia proportions appear lower in the metastatic site compared to the other sites, though it is not statistically different. And the neuron proportions do not differ significantly across sample sites. And then from all of this data that we accumulated, looking at both the primary tumor as well as the metastatic tumor and the normal tissue, what are we doing in the future? And so all of these proportions and all of these, the data analysis that we have conducted will be then used in the Munson lab to create 3D in vitro models. So all of these different cell types will then be placed into an in vitro cell culture model that can then be tested with various different targets, specifically looking at focused ultrasound delivery, and then also drug delivery as well, specifically in ONC201, which is in phase 3 clinical trials for this tumor. And I'd like to thank specifically Ria and then Ethan, who is a fellow classmate, for kind of taking this project on to the next step. And with that, I would like to thank the members of the Munson Lab who were very helpful and instrumental in my project. And with that, are there any questions?
Thank you, Sarah. Any questions for Sarah? All right.
Hey, Sarah, very, very nice job. Very important to have this characterization done, as you know, so glad to see the work. I'm just curious, one of your slides showed from the normal tissue in the patient that had metastatic disease there, I guess. When you look at tumor cells in the so-called normal tissue, even though it's very close to zero, it's not zero.
Correct.
And so are you just looking at a couple cells that have migrated and started to seed an area, or how do you interpret that?
So that interpretation, it's very important and very interesting. So those, you can see a little cluster right there of like a positive staining in otherwise normal tissue. So I'm going to be going back and looking specifically at those tissue samples to see if it's background staining or if more specifically we are seeing a little bit of infiltration. But overall, for a majority of the patient samples we see, that is just background staining.
Okay, thanks.
Mm-hmm.
Hi, Sarah. Thank you. I was just curious about the decision to use the patients as their own controls, and if you were able to consider something like difference in treatment protocols, radiation, chemotherapy, and yeah, just generally. how you feel like that could have affected your research.
That's a very good question and something that we thought about. All of these patients have had numerous different therapies because these are autopsy samples. These are not biopsies at the beginning of treatment. So they've all had various doses of radiation, various investigational drugs. And because of our 20-person sample size, we're not really able to, with statistical significance, correlate the different cell types and the number of different cell types to the various treatment targets that they received. I did look at that and nothing was significant, but it is an interesting theory to move forward with. And in terms of the controls, having the patient serve as their own control, I think it's important for one, because they received so many therapies, their normal tissue received radiation just like their tumor tissue did. And so to kind of take that confounding variable away, I think is important. We also don't necessarily have a plethora of normal brain tissue from pediatric patients that we can use as controls.
Thank you so much, Sarah.
Our last talk for the session will be from Alana Hull. Alana worked with Dr. Martha Ann Bell from Virginia Tech's Psychology Department. Dr. Bell tells us that she feels fortunate that her brief presentation in Research Live during the first year resonated with Alana because she brought into the lab rigorous research skills from her time as an undergraduate research assistant. Alana immersed herself in the developmental cognitive neuroscience literature and designed a unique research project using data from an NIH-funded study on infant brain development. Alana's innovative project has the potential to change our understanding of early brain network development. So now Alana's going to tell us about neurofunctional connectivity across the first year using EEG coherence and task behaviors and to examine rudimentary neural networks.
I'm sure everything works. All right, so my name is Alana Hull. Thank you all for coming, and I'm going to be talking about infant neural networks. So there are many neural networks that are known both in adults and infants. Today I'm going to be talking about two. One is the default mode network, or the DMN. The other one's the frontal parietal network, or the FPN. The default mode network is known to be upregulated during wakeful rest and introspection, whereas the FPN conversely is known to be upregulated during tasks that require thinking. And as you can see in these images here, these are typically studied using fMRI. However, this poses a significant challenge in infants because in order to get an infant to lie still enough for an MRI, they have to be either sedated or asleep, which makes it nearly impossible, or actually impossible, to get them to do anything while we're measuring these networks and looking at these networks. So part of my study was to try to find a different modality to examine these networks, and my lab uses EEG, so we're going to be talking about EEG. And just as a reference for the rest of this talk, I'll have this little guide in the corner. The DMN is increased when you're being introspective or meditating. FPN is increased when you're thinking. So that's just to serve as some memory for you right there. So our main question was, how does functional connectivity develop in infant brains? Secondary question, of course, just why do we care about the DMN and FPN in infants? So as I said before, this is not well studied in awake infants. And so my lab, as well as the scientific community in general, is always trying to get more knowledge about brain development and how the brain works. And then also, we care about these networks because we've found clinical correlations, clinical significance in these networks in other populations. So we have found that even though the DMN is a good thing and everyone has one, too much DMN has been associated with attentional deficits and behavioral dysregulation in multiple age groups, as well as multiple psychiatric and neurological conditions. So to talk about how we measured these networks in our infants. So again, we're an EEG lab. So we had infants in the EEG caps do a variety of tasks from 5 months to 12 months. And in total, we had 48 infants who came in monthly. And then to measure the EEG, we are looking at coherence of approximations of these networks. So the DMN is in blue, the FPN is in red, and coherence just means kind of how often do these 2 points temporally coincide with one another. So to jump right into the results,
we're looking at how these networks develop and diverge. So also this serves as kind of a proof of concept of can we see these networks in these infants using EEG? And so a couple interesting things to point out here. One, if you compare the 5-month point to the 12-month point, there is growth of these networks as we expected across age. We can also look at the divergence of these networks. So at 5 months old, they're really not different from each other. And this makes sense because the DMN and the FPN in a 5-month-old is very immature. But the interesting thing is we see these two networks diverge from each other, which was as expected, but it's really neat that we're actually seeing it in our data. And this coincides with kind of the known growth period of these networks. So in prior studies, we know that the DMN typically shows growth in the like 9 to 12 month range, which is right around when we're starting to see that significant difference and divergence. And then the other thing that's interesting about this is that the red line, the FPN, is always above the DMN or the blue line. And this makes sense because while this data was being collected, these infants were doing something. So we want to see the FPN higher than the DMN because that means that because the FPN's a thinking network, they're thinking while they're doing something. So that makes sense. And then I want to highlight this one specific area on this graph. If you want to see the whole graph, talk about, you can come to my poster session. But this one area and specifically, we wanted to see if what we're seeing, what we expected behaviorally is what we're seeing in these networks. And the answer is yes. Higher DMN means lower infant attention. And we can see this by, so the purple line is the DMN. First, we divided these infants into a group that was generally more attentive and a group that was generally less attentive. And we wanted to see differences in their networks. So the solid purple line, the DMN low attention group, has higher DMN than the orange line, which is the DMN high attention group. And we only see this at 12 months, which again makes sense because 12 months is when these networks are most mature for our study. So these networks continue to grow throughout much later in life. So to wrap up, so with conclusions and future directions, first of all, the DMN and the FPN can be tracked developmentally using EEG. Again, this is kind of proof of concept, but it's really cool because as I'm jumping into future directions, it opens up a broader window to look at a bunch of other things in awake infants, these neural networks in awake infants doing a whole variety of things. So then again, the DMN EEG at 12 months aligned with our observed infant attention, which is really cool because these numbers that we're getting from the EEG don't often go along necessarily with what we're seeing behaviorally. And so that was the big component here, was we actually were able to quantify behaviors and see differences in their neural networks. And then lastly, I already alluded to this, but if we can use EEG to look at these networks, we can use EEG to look at potentially other infant neural networks, and then how they relate to other infant behaviors. And I just want to thank my mentor, Dr. Martha Ann Bell, and the whole lab.
Great talk, Alana. Do we have any questions?
Thanks for your presentation. I was just curious, is there any kind of like intent to maybe follow these patients, probably not these specific patients, but like into the future to see if you can use this DMN and the other one as like predictive measures for, as you put it, like attention deficit or whatever. So like, do you think there's any ability to kind of predict outcomes further down the line? Maybe not this early, like the first 5 to 12 months, but like in a 1-year-old or a 2-year-old.
Yeah, so that's definitely a possibility. If we're looking at some of the disorders that the DMN especially can be implicated in, it would be ADHD and autism. Most of those aren't diagnosed until significantly later in life. So this study ended at 12 months old. All the infants in our study were typically developing. So as far as we knew, they had no diagnosed disorders at that time. That's not to say they didn't maybe go on to develop something. We don't know. That would be an area for future research, especially in
like a clinical psychology lab, that could potentially be something that we could collaborate with.
So much.
Yeah, you're welcome.
Okay, before we break for the poster session, I want to remind you there are QR codes plastered all over in Riverside 4. If you're a student, please use the QR code to vote for your particular set of poster presentation awards. If you're a faculty member, there is also a survey for you all. We would like to award students based on faculty's perceptions of a couple of different items. So same QR code, I believe. Click the QR code, you're either faculty or student. Please be back here at 3:30 for the last set of rapid fire talks. Thank you. All right, welcome back, everyone. If you are a student, I know you've been asking about QR codes, and for the QR code for the second session, you're welcome to scan the second session QR code on your way out. Sorry about, we didn't have those out right away. We are going to finish up this oral presentation session with the rest of our students who earned letters of distinction in research scholarship. I didn't have a chance in our earlier session to go through the criteria that were used to select these students. We gather our evaluators' opinions and comments, as well as mentor input to select these letters. And the criteria we give everybody to think about as they're choosing whether to nominate or not is the students, is the research quality, significance, relevance, innovation, and then the clarity with which the student communicates, both in written form and then in oral form. So it's all of those factors, and that's who you get to hear from today is those who are selected. So today we're gonna, before I forget, posters. So Jessica Flowers is in the midst of collating results from all of the poster voting. So if you haven't finished yet, please hit submit now. She's going to do a hard cutoff at 3:40. So please get your votes in now, and then we will award those people who win at the end of the session. Okay, so our first presenter is going to be Mia Edelson. She worked with Dr. Emily Evans Hooker from Shady Grove Fertility and Virginia Tech Carillion's Department of Obstetrics and Gynecology. Dr. Evans Hooker says that Mia has been an amazing student working with her. She's navigated challenge after challenge that she's encountered with ease and grace. She's proactive in anticipating hurdles and making sure that she has all of the resources necessary to complete her project. So now we're going to hear about the work she did looking at the effect of a mindset management intervention on stress levels in women with infertility. Mia.
Hi, everyone. Thank you for being here. Thank you for the introduction. So my name is Mia, and I'm going to be presenting on the effect of a mindset management approach on stress levels in women with infertility. So after being diagnosed with infertility, the next step often in a woman is to go on to see a fertility specialist. In our case, that's Shady Grove Fertility Clinics in Roanoke and in Richmond. And after this initial consultation, a treatment plan is often decided. However, it's pretty well known that in this population, there are high levels of stress and higher rates of certain psychiatric diagnoses. However, mental health interventions aren't currently part of the standard of care. Some interventions that have been looked at are yoga and mindfulness-based group counseling, but one intervention that has yet to be studied is organic conceptions. Organic Conceptions is a 9-step cognitive-based therapy program. It gives patients tools to reframe the emotional side effects associated with infertility. It's actually already been implemented in fertility clinics around the world, and they created a 10-week program for our patients that includes all components of their program. So our hypothesis is that self-reported stress levels will decrease in patients with infertility who complete this intervention. These stress levels will be measured using the Copenhagen Multi-Center Psychosocial Infertility Fertility Problem Stress Scale, or the COMPI scale. What's great about this scale, it's been proven to be reliable, it's validated, and it's been used already in different studies. And it's split up into 3 different domains: a personal domain, a marriage partnership domain, and a social domain. It also pinpoints infertility-related stress. As we know, a lot of things in our lives can cause stress, and this specifically asks about infertility-related stress. So this is an interim analysis. So far, we have 38 patients enrolled. We'll be enrolling 66 patients, and medical students on our study will continue enrollment after I graduate. But for demographics so far, we found that the control group had higher relationship length. The intervention group had higher rates of certain psychiatric diagnoses, interestingly. Attendance rate was pretty remarkable in both groups, although there was a significant difference. Retention, which is attendance at follow-up appointment after the initial consultation within 6 months, there was no difference between the 2 groups. And at baseline, the intervention group did have higher stress related to certain components of the COMPI scale, such as their relationship with children. So we believe that perhaps the fact that they had higher rates of psychiatric diagnoses at baseline may have contributed to those higher baseline stress scores. So moving on to our primary outcome results, day 0 represents when they completed survey 1 and when they were enrolled in our study. This was either shortly after or before their initial consultation. Then the intervention group completed a 10-week intervention and the control group did not complete any intervention. And at week 10, they completed survey 2. And then at week 16, they completed a 3rd survey to see if there was a long-term effect on stress. So starting with life disruption, we found that between day 0 and week 16, and also between day 0 and week 10, there was a decrease in stress in both groups. Similarly, with dealing with infertility, between day 0 and week 16, there was also a decrease in both groups. And we believe that this may be because participants, when they go through their first infertility consultation, may feel more supported, may, communicating with nurses, physicians, and other providers that may be contributing to this decrease. One interesting finding we found was that between day 0 and week 10, in terms of stress related to their relationship with pregnant women, there was an increase in the intervention group and a decrease in the control group. This may be because the organic conceptions approach did discuss communicating with pregnant women, and perhaps this made participants more aware of this issue. For mental health, between day 0 and week 16 and day 0 and week 10, we found that there was a decrease in both groups. And similarly, it was the same case with the personal domain total. This may be because participants, no matter what group they were in, may have developed resilience and coping mechanisms over time. For partnership domain between week 10 and week 16, so later on, we found that there was a decrease in stress in the intervention group and an increase in the control group. And this was the same for sex life and partnership domain total. This may be because the Organic Conceptions program did teach participants tools on how to navigate their relationships, communicate with their partners, but this may have taken some time to implement. So this is why perhaps we're not seeing this until later on. For relationship with family, between day 0 and week 10 and day 0 and week 16, we found that there was a decrease in the intervention and an increase in the control. This may be because the intervention had an early impact on relieving social stressors such as family pressures. For relationship with family in law, though, interestingly, between day 0 and week 16, there was an increase in both groups. One thought I had is family in law, since it's more distant family, maybe more removed from the struggles in the beginning and become more involved with time, and that could potentially lead to more stress in both groups. For social domain total, we found that there was a decrease in the intervention group and an increase in the control from day 0 to week 16. And lastly, for total stress scores, we found that from day 0 to week 10, there was a decrease in both groups. However, from week 10 to week 16, there was a decrease in the intervention group and an increase in the control group. This may be because overall, as I mentioned, the Organic Conceptions program may have had a delayed but impactful effect on infertility-related stress. So lastly, I'd like to acknowledge all of these individuals on this slide, especially the patients who sacrificed a lot of time to be in this study and were potentially helping patients in similar situations in the future. And I'll now open up to questions.
Thank you, Mia. Does anybody have any questions for Mia?
Thank you for presenting. Could we go back one slide?
Yes.
I was just curious, like, as far as the control group, like their stress levels increased between weeks 10 and 16 compared to like day 0, correct? Like at their baseline, they took the survey and then later on they took it again and their stress increased. Do you have an idea of why it would increase over that like 16-week period?
Yeah, so are you asking for the total stress score specifically, or which component?
I mean, I guess like both the total stress score, but I noticed in, I guess, like the partnership domain, there's a marked contrast. And I was just curious if you knew, like, I can understand why the intervention group would decrease because that's like purpose of organic such the intervention. I was just curious why the control maybe would increase instead of stay the same, or something like that?
Yeah, so one thought we had is that perhaps the control group had a delay in that stress. Perhaps it takes some time since they're at the start of that infertility journey. You know, starting treatment can definitely be stressful, and that does take a few weeks to begin, depending on whether or not they choose IVF or another treatment. So perhaps they're seeing higher stress later on in their process because of all those hurdles that they encounter later on.
All right, thank you, Mia.
Our next presenter is Michael Klingener, working with Dr. Yassine Sassi from FBRI's Center for Vascular and Heart Research. Dr. Sassi shares that Michael is one of the most talented students he has trained. In addition to his exceptional talent in conducting and analyzing experiments, Michael's a dedicated teacher. His tireless devotion to teaching molecular and cell biology techniques has amassed a great deal of admiration from others in the lab. Over the last few years, Michael has shown the attributes of an inquisitive, enthusiastic, hardworking scientist capable of working independently on complex projects. He's not only familiar with all aspects of his own project, but also has a comprehensive understanding of cardiac and pulmonary physiology in general. So now we're going to hear a little bit about Michael's work targeting the extracellular cyclic AMP pathway in idiopathic pulmonary fibrosis.
Well, thank you for that really nice introduction, Dr. LeConte. Hopefully I don't forget everything and prove everybody wrong. But for those of you I haven't met, my name is Michael, and I'm going to talk today about idiopathic pulmonary fibrosis. So to start with an overview, this is a restrictive lung disease. And what we see in the pulmonary interstitium is this deposition of fibrotic tissue. That's in that space between the airways and the vasculature. And that process is driven by fibroblasts. Now, ultimately, for patients who receive a diagnosis of IPF, at that point, they have about 3 to 5 years of life expectancy. Unfortunately, there's not too much that can be done to change that. Now, there are some specific antifibrotic therapies, but they have a significant side effect profile. They're costly, and there hasn't been a consistent mortality benefit shown in the literature. So having said all that, the overarching question I asked was, can we find new molecular targets to develop new therapies for lung disease like idiopathic pulmonary fibrosis? Now, over the years, it's emerged that intracellular cyclic AMP signaling is protective in the setting of pulmonary fibrosis, and these are some reports showing that. We also know that this protective signal is reduced. So there are some groups out there, including ours, that are looking for ways to activate intracellular cyclic AMP signaling as a means to develop a new IPF therapy. Now, there are, several known ways to do that, and I suspect, these molecules are familiar to many of those in the audience. But there's actually a lesser known way to activate intracellular cyclic AMP signaling, and that's with extracellular cyclic AMP. So to kind of take you through how that might work, I'll show you the pathway here. So the same cyclic AMP that's inside the cell is now outside. It gets processed by 2 enzymes into adenosine, and that adenosine binds a GS-coupled GPCR, and through that, you get elevated levels of intracellular cyclic AMP. And having said that, my hypothesis is that treatment with extracellular cyclic AMP will oppose the pathological changes in experimental models of pulmonary fibrosis through activation of the intracellular cyclic AMP pathway, as I just walked through. Now, in order to address that hypothesis, our lab uses the bleomycin model of pulmonary fibrosis, and I'll go through that quickly. In this paradigm, you have a mouse that receives an intratracheal injection of bleomycin. That results in a lung injury. In response to that injury, there's an inflammatory phase, and that's followed by a fibrosis phase. And what we see in the fibrosis phase roughly mimics what we see in the human condition of IPF. Now, kind of using that setup, I'm showing you an experiment here on the right where mice receive 2 bleomycin injections at day 0 and day 7. And then from days 14 to 28, either received treatment with the extracellular cyclic AMP or no treatment. And then we looked at survival at the end of that experiment. And what we saw was that in the bleomycin plus no treatment group, about 40% of those mice were surviving at the end, whereas about 80% of the mice in the treatment group were surviving at the end of the experiment. So this is great, right? Because as I alluded to earlier, if we're going to have a treatment, we want to see a mortality benefit or survival benefit. But ultimately, this was kind of like we saw this as an incomplete therapeutic response. So we had 40% survival to 80, not like 40 to 90 or 40 to 100. So we kind of wanted to dig into that a little bit more and understand why we were seeing that. Now, when I walked through the pathway earlier, I didn't explain the left part of this diagram here. So even if you have the protective intracellular cyclic AMP, what can happen is there's this PDE family of enzymes where certain family members can cleave and turn off that signal. And that reaction is shown here on the right. So this was kind of something that made sense to us as a possible explanation for why we were seeing that partial therapeutic response. Maybe we have the protective signal, but it's just being turned off by a PDE. So to kind of dig into that further, we did an mRNA screen looking at different PDE transcripts. We used two models, so lungs from bleomycin-treated mice and human lungs from patients that were diagnosed with IPF, and the lung was tissue, I should say, was collected before transplant. We saw that PDE 1, 2, and 3A were elevated in both models. So we decided to look into those further from kind of the group of PDEs that we started with. Now, since PDE is an enzyme and has activity, we're more interested in what's happening at the protein level. So we looked at that next. And what we saw was that it was actually only PDE1A that was elevated at the protein level, whereas 2A and 3A were close to baseline or even a little reduced. And this is in the bleomycin model again. And this was interesting to us because PD1A is one of the PDEs that can cleave cyclic AMP, whereas there are others that can only cleave cyclic GMP, for example. So again, kind of thinking as to why we might be seeing that partial therapeutic response. And this is kind of where the project's at now. I'll just wrap up with some conclusions and future directions. I have shown you that extracellular cyclic AMP treatment improves survival in the bleomycin model of pulmonary fibrosis. We saw that PD1A, that enzyme that can cleave the cyclic AMP molecule, is elevated in models of pulmonary fibrosis. And I think the big takeaway here is that whether you're trying to activate intracellular cyclic AMP signaling with our approach, with the extracellular cyclic AMP, or any of the other approaches, that you may need to combine that therapy with a PD inhibitor for a full therapeutic response. Now, as a future direction to address that last point, we'd like to repeat this experiment that I showed you earlier, but now just imagine a fourth condition where we have the extracellular cyclic AMP and a PD inhibitor. And as I mentioned, maybe or hopefully we would see higher survival at the end in that dual therapy group. And with that, I will thank everybody in the lab. Unfortunately, this is only a 5-minute talk. I could talk for 5 hours about how great the lab is, but hopefully by me saying that, you know that's a really wonderful place, and everybody has been just so helpful and kind over the last 3 years. I'll thank our collaborators and the VTC research domain and funding agencies and all of you for listening. Thank you.
All right, any questions for Michael?
Hey, Michael, great talk, man. So I was just curious, why use the extracellular cyclic AMP versus just adenosine based on your pathway?
Yeah, so that's a really good question. So if let's say you use native adenosine, for example, the half-life is very short. There are some synthetic adenosine agonists and antagonists and different molecules you can use to manipulate those receptors. But I think kind of for me, if you can target an endogenous pathway with the endogenous ligand and manipulate that, that's usually more favorable than using, let's say, a synthetic molecule that you make, and maybe you never fully characterize all the off-target effects and so forth. So that would be one thought. But kind of as we're going through some of the mechanistic studies, you will see some of those same effects recapitulated with different kind of adenosine receptor modulators. So it's a really good thought and something we've thought about too.
What sort of fibrotic changes did you see in the mice? Did you look at like pathological staining of those mice?
Yeah, that's a really good question. So I had it in here originally and I cut it out because it felt like I would take too long to explain a lot of things. But so the bleomycin model, there's some, I guess, controversy in the field how well it mimics the human condition of IPF. So you'll have the bleomycin drug kind of enter the lungs, and the injuries will be in like the larger airways, basically where the drug enters. It doesn't 100% mimic what you see, for example, in the human condition of IPF. But kind of one of the thoughts is, and again, I didn't show too much of this data here. If you use your animal model, that's imperfect, but the one that's recommended by the American Thoracic Society, you combine that with in vitro primary fibroblast cultures and human tissue from IPF patients, that if everything's sort of agreeing, then maybe it's not a function of the model, right? If you're finding that it's actually something like kind of a mechanism that's common to all those models. But yeah, I think it's a good point. I didn't, and just to circle back, the same changes that you saw in the survival, or the same groups in that survival experiment, there was a histological analysis with kind of looking at fibrosis in the lung parenchyma. And you see something similar there where there's control, you have a significant amount of fibrosis in bleomycin only, and then come back to baseline or closer to baseline with the extracellular AMP treatment.
Thanks.
Thank you.
I was wondering if there's a proposed vehicle for introducing PDEIs into these patients or into these models, because I can imagine that a systemic infusion of a PDEI is going to be probably not the best thing versus infusion of cyclic AMP, not so bad.
Yeah, so cyclic AMP is actually much easier to work with. It's water soluble, relatively stable. The PD inhibitors, as we found in lab, as we're kind of researching different ones and testing them out, harder to solubilize, need special vehicles, and yeah, you would want local administration. I think kind of now, haven't thought too much about that, so we're more on kind of the side of just how do we deliver the extracellular cyclic AMP, so through like, imagine like an albuterol inhaler or nebulizer. The PDE, I think we are hopefully going to see the results of that future direction experiment I proposed in the next months or coming weeks, and then from there, if everything works the way we hoped it would work out, we'll think about that more. But it's a really good point. They're much harder to work with, and there's a lot of off-target effects. There is a stage 3 trial underway now for a PDE4 inhibitor that I believe is just orally administered, but the results are not fully kind of compiled. It's coming out, but the results from the phase 2 study were encouraging. So
thank you.
Thank you so much, Michael.
Right. Thanks, everybody.
Our next speaker is Bria Hall. Bria worked with Dr. Henry Rice from Duke, as well as Dr. Brian Meyer from our Department of Emergency Medicine, as well as our very own Kara Spivey. Dr. Meyer shares that working with Bria was an absolute pleasure. She integrated a group of researchers from Duke and VTC, navigating several IRB hurdles, recruited new students, but most importantly, made a massively complicated study manageable. Every time someone had an issue or a challenge, Bria took it on personally and solved it, even during her difficult clinical rotations. Most importantly, she made everyone feel like they were a valued contributor, even though all the credit should really go to her. Dr. Rice emphasized that Bria is extraordinarily organized, team-focused, insightful, and has been an inspiration to work with. So now we're going to hear Bria tell us a little bit about understanding family-level decision-making in pediatric surgical care, a study that was done with mixed methods.
Thank you, Dr. LeConte, and thanks to just an incredible group of dedicated team members who are really working to make this happen. So before we jump in, a little bit of background. So we know that social determinants of health are important in clinical outcomes. There's a lot of kind of national high-level population data that shows that children from lower socioeconomic areas are an increased odds of perforation rate. However, what we don't understand is really how social determinants of health are important to families themselves and how they make decisions based off of that. There's also some conflicting evidence in the literature. So we've also seen national data has shown that among insured children, families who are a higher income quartile are also have been shown to have increased rates of perforation, which is something that conflicts a little bit with other studies. Oops. So we are using the proxy condition of appendicitis, and then also using perforation rate as a proxy measure for delays in care. This has been well established in the literature. Our big research questions were what family level factors impact clinical outcomes and what factors are important to families. And to address those, we looked at really two key aims. One was kind of to identify factors that contribute to family level decision-making, and then also to look at those association between those factors and perforation rate. So to address these aims, we're doing a concurrent, convergent, prospective mixed method study. So we're including English and Spanish speaking patients and their family members from 2 sites, both at Duke and here at Carilion. We're collecting quantitative data, which is really just standardized surveys and also clinical data. And then a subset of those patients are also being included for in-depth interviews. The in-depth interviews really allow us to kind of ask families about what factors are important to them and kind of understanding what decisions they're making. while the surveys kind of give us just more information on clinical data and social determinants of health. The data integration allows us to use that qualitative data and interview data to expand on some of our quantitative findings. Jumping into our first cohort, so this analysis includes the first 87 patients. Kind of overall, there is a balanced representation of perforated and non-perforated appendicitis. There is, from kind of an ethnicity standpoint, it is representative of the local populations, however, not from a race perspective. Black families were under-enrolled in this study, so that's something that we're working on. Overall, there were no significant differences between demographic variables and perforation status. As far as factors that were associated with clinical outcomes, we found that children with perforated appendicitis had families that had a higher income level. This is something that was surprising, and we'll come back to this in a minute. We also found that children with perforated appendicitis had an earlier presentation at a healthcare facility, meaning that even though there were not any differences in the time of onset of their pain or in the time of diagnosis, patients with perforated appendicitis were presenting at a PCP office, in urgent care, or an outside ED earlier than the non-perforated patients. Again, this was something that was surprising, and we'll come back to this. We looked at a lot of other factors. Thus far, they have not shown any significant relationship between general insurance type, public versus private. There was no significant relationship. Also, no relationship between education, proximity, adult responses to children's symptoms, adverse childhood experiences, etc. So looking at our qualitative data and kind of understanding what factors were important to families. So this qualitative analysis is, again, preliminary. It includes the first 26 patients who participated in the interviews. We identified lots of codes that were then kind of further categorized into themes, being internal and external themes. And patients really identified two key decision-making conflicts that they felt that they had to do by themselves as parents. The first was deciding if and when to seek care. The second, deciding where to seek care. And then the third was that kind of the third phase is once they're at the hospital, they felt like they leaned more on shared decision-making and they weren't primarily responsible for decisions after that point. When we looked at drivers of what was important to families and drivers of their decision-making at those 2 points, kind of this first decision-making conflict about when to seek care, families really relied on objective signs and symptoms. So fever, vomiting, functional changes that they saw in their child really drove decisions around this. Also, parental prior health experiences was something that emerged as dominant. So this one, parent talks about how an experience she had when she was a child with her brother, that kind of now impacts the decisions that she makes for her own children. When we think about that second and took a look at kind of that second key decision-making conflict around where to seek care, there were a lot of factors that came into play here: availability, health system factors, but one of which was a key driver was that of concern for out-of-pocket costs. So participants from higher income families are really concerned about higher copays at the ED, and this drove their behavior to seek care first at out-of-patient offices or at urgent cares, places that have a lower copay. While lower income families felt that their Medicaid was protective and that they were able to seek appropriate treatment at the location they thought was most appropriate for the child's pain. So some key takeaways from this preliminary data. One is that the key drivers of decision-making, this changes across the care continuum. So this is really important when we're thinking about, potential interventions, when we're thinking about potential decision supports tools for family, or also even health information sources that families use at that point. The second being that, these findings suggest that patients with the higher income levels, high out-of-pocket costs are really concerning for them, and really maybe a deterrent to them seeking care in a timely fashion at an appropriate facility. A lot of these families talked about seeking care at other places with lower copays compared to families who were a lower income and had Medicaid. I think overall, this also emphasizes the importance of collecting kind of granular family reported data on financial factors, as opposed to a lot of our population studies right now that rely on income approximations like zip codes. So next steps is we're continuing enrollment. Also, the analysis so far have only been univariate analysis. So our study team is next going to be working on model selection and the multivariate analysis. And lastly, I think given kind of the lack of the quantitative data on more kind of granular level factors of insurance, so insurance subtypes, deductibles, cost sharing, out-of-pocket costs that family have, we don't have that data right now. So that's something that our study team could consider doing participant checking to kind of follow up on these unexpected findings. Any comments or questions?
Anybody have questions for Bria?
Hey, Bria, that was a really great talk. And yeah, kind of as you mentioned in your wrap up, that finding was sort of unexpected, that higher income families are more concerned with cost. So kind of thinking more about that, I was wondering to myself if you had any data on, let's say, a higher income family that was previously on the lower end of the income scale, and if their decision-making changed in accordance with their income.
Yeah, that's really interesting. There was one, so overall, no, we don't have that data, but there was one interview of a family who had recently switched. And I think we actually have their quote represented here, but they talked about how currently they're on Medicaid. Previously, they had a really high deductible insurance plan, and the parents actually talked about how their decision-making this time was different compared to previously, and they didn't have to worry about that. So it's a great question. I think it's something that kind of clinically, we see a lot of, we see that clinically, we see the families talk about that, but there's just a lot of positive research on how families are using that.
I'm going to make a comment because I think I've run into this a lot in my practice is when you're in practice, think about these types of drivers of decision-making, because I know when I was in the ED and we look at the patient, go, oh, just come back. If you're not better in 48 hours, then we'll give you the antibiotic. For a lot of patients who do have private insurance and have a $200, $500, $800 copay every time they walk through those doors, coming back isn't feasible necessarily, just to check in. And so having a plan in place that works, keeping in these factors in mind is really important when you get out there to practice.
That's a great point.
Thanks, Bria.
Next, we have Ryan Morse. Ryan worked with Dr. Eli Vlasevlevich from the Biomedical Engineering and Mechanics Department in Blacksburg, and Dr. Jay Rao from the Department of Internal Medicine here in a lab at Carilion. Ryan's mentors share that his novel application of histotripsy technology has required a large number of experiments in collaboration with the two labs, so spanning Blacksburg and Roanoke. And then managing a large collaborative project between these two groups is not an easy task, but Ryan has shown the ability to lead both his own independent research project as well as mentoring others on the team to expand this work beyond the treatment of catheters that we're going to hear about in just a minute. Ryan's efforts have laid the groundwork to explore large grants and a human translational process in the upcoming years, bringing us one step closer to seeing this technology advance into the clinic. So now we're going to hear about Ryan's work on catheter-based medical device biofilm ablation using histotripsy.
All right, well, thank you very much for that introduction. Yes, so today we are going to be talking about histotripsy for the non-invasive treatment of biofilms in catheter-based medical devices. So just starting off with a little bit of a background here, biofilms are a protective matrix that bacteria secrete when they're attached to medical devices that really shields them from their outside environment. And these are a massive source of hospital-acquired infections. If you've ever had a patient in the hospital that's had a urinary infection associated with the urinary catheter, it was probably because of biofilms. And so the real issue when it comes to treating these is that they are almost completely protective against antibiotics or your body's immune system. They're really, really hard to deal with. So previously, the standard method to deal with these was to just remove whatever medical device you had in place. That is, for a number of reasons, not ideal. It's very uncomfortable for the patient, it's expensive, it's time consuming, all of that. And so our solution was to use a method called histotripsy. So histotripsy is a non-invasive focused ultrasound therapy that's recently been shown to be highly effective at ablating these biofilms. We've had several students from this school who have already had research projects on this and have shown just how effective this is. But there are still several major problems that have to be overcome before this can be applied in the clinic. And the first one, and the really big one that I wanted to address with my project, was trying to reduce the treatment time for these biofilms. So current treatment parameters take about 6 hours to treat a standard length urinary catheter. So that's about 44 centimeters long, about yay long. And so we really needed to get that down because there's no way that we can effectively have a nurse, a medical student, a doctor, whoever sit in a room for 6 hours treating a biofilm. So like I said, my research question was, can we ablate these biofilms in a clinically reasonable time frame? So a little bit about the methods here. I won't get too much into it, but we used a Pseudomonas aeruginosa-based biofilm in these medical catheters. And we treated these with a 16-element transducer. So basically what this is it's 16 individual ultrasound probes that are all pointed at one individual location in a fluid, or in this instance, a catheter. And then we quantified our results using bacterial cultures as well as spectrophotometry. So in trying to improve the treatment speed here, there were really 3 areas that we wanted to optimize. The first was determining the minimum effective dose of histotripsy required to ablate biofilms. So previous studies on this had used what we suspected to be a far, far higher dose than what was actually necessary to ablate biofilms. So we wanted to figure out what the minimum effective dose was to ablate these. And then the second part was trying to improve the treatment efficiency. Previously established methods had used what we call a point-based application system. So functionally, what they would do is they would apply 500 pulses of histotripsy at one point on a catheter, and then they would slide down the catheter another 500, and so on and so forth. And we said, I think reasonably, that that's probably not the most efficient way to do it. So instead, what we decided to do was just continuously scan along the length of the catheter without stopping. So just a continual movement while the transducer is on and applying a certain number of pulses per second. And then finally, we wanted to see if increasing the pulses applied per second would also increase the speed at which we could ablate biofilms. So starting off with some of our results here, the first study we looked at was trying to characterize that minimum required dose. So the graph that you can see on the far left here was looking at trying to decrease the number of pulses per point that we talked about. So we took the original parameter of 500 pulses per point and decreased that all the way down to 100. We still saw nearly complete biofilm ablation. So then we tried to increase the distance between these points. We increased this distance by 20 times with the lower minimum required dose, the pulses per point, and we still saw almost complete biofilm ablation. So finally, for the last graph that you can see on the far right, we decided to just do away with this point-based application and just do a continuous scan. From this, we saw that we still had almost complete biofilm ablation at only a 20-second scan across a 2.5 centimeter catheter. So we wound up losing biofilm ablation effectiveness at the 10, 5, and 2.5 second scans. So we wanted to see if we could get that back by increasing the pulse repetition frequency, the number of pulses we're applying per second. And what we found was this was highly effective. So when we did 500, 750, and 1,000 hertz, we restored almost complete biofilm ablation at these speeds. And so we were able to get nearly all of the biofilm out of a catheter in about 1 centimeter per second. So the next question was, can we also kill bacteria? You know, we've been ablating these biofilms, which is great, but that will shower bacteria out into the fluid, which we then have to address usually by flushing the catheter. But sometimes flushing the catheter is not the ideal solution. So what we found here was that at higher doses, histotripsy can effectively kill bacteria. This had also been previously established, but what we found was that we can still do it in this much faster time frame using our new parameters. So with just a few minutes of treatment, we can kill 99.99% of bacteria in a fluid with this technology. All right, so the important slide here. Why does all this matter? So there's a couple of major uses for this technology. The first that we talk about is that treatment times to ablate biofilms have been massively shortened. So like I said, it was about 6 hours to treat a full-length urinary catheter originally. We got that down to under 1 minute, which makes this a technology that can potentially be used in the clinic for the treatment of these catheters without having to remove them from the patient. And then the second is that these improvements extend into bactericidal effects, being about 10 times faster than previous reports. This has allowed for a whole host of future projects. We've got several medical students in the room that are currently working on these. using ventroperitoneal shunts, using surgical implants. There's a number of different applications of this technology that we at Virginia Tech are currently looking into. So some of the future directions that we also want to look at here are the treatment of polymicrobial biofilms. So in the clinic, you won't just see a Pseudomonas biofilm. You'll have Pseudomonas, you'll have E. coli, you'll have Staph epi, you'll have yeast sometimes, and they'll all just pile on top of one another and produce this super biofilm. So we want to see if we can effectively treat that as well. And then finally, we want to expand our research into in vivo studies and clinical trials. And so I couldn't begin to acknowledge everybody on this project. It is a huge team over at the Blacksburg campus, but here's just a couple of names. And thank you very much.
Great talk, Ryan. Any questions?
Fantastic presentation. I had a quick question in terms of the bactericidal effects. At the higher frequency levels, are you seeing any potential detrimental damages to the ural epithelium that could potentially pose long-term consequence?
So excellent question. What we are trying to do with this technology is just target the lumen of the catheter itself. But the current methods that we use do have a little bit of cavitation on the outside of the catheter that can indeed damage the urethra or whatever epithelium that you're dealing with at the time. So what we're trying to do now is focus on using new approaches that will allow us to only target the inside of the catheter. So the lab in Blacksburg is currently working on developing these things called nanoparticles, which will basically reduce the cavitation threshold and ensure that you can only get bubble formation inside of the catheter itself.
Very cool. Thank you.
Thanks for the talk. I was just curious, do you think, given how much quicker in theory this is now, it would eventually become more of like almost like a prophylactic measure? You get your catheter, you go in for an appointment, and like before it reaches the point where you require treatment, or you could just do this like ultrasound treatment semi-regularly or whatever and prevent formation? Or is that like super far down the line? You mentioned you're trying to get to the in vivo studies, the clinical studies, right?
So another excellent point and ideas for anybody that wants to join our lab here. I didn't have enough time to research this while I was at Virginia Tech, but yes, I strongly suspect. So I did like a very quick scan across the catheter. I bet we could go at several times faster than that on catheters that don't already have a biofilm in them, and just prophylactically, you send somebody into the patient's room every day and just do a very quick scan that deals with whatever little biofilms in there. I think that is probably the biggest potential application of this. So take notes, anybody that wants a research project.
Hey, great talk, Ryan. That was really, really interesting. I have a question about the durability of the effect. So if you were to optimize kind of, sterile conditions and so forth, and you remove that biofilm, would you expect it to stay removed? And I guess kind of what I was thinking was if you're kind of applying this treatment, do the physical properties of the catheter change? Hypothetically, you make some fissures in it, and now it's like there's a place for bacteria to anchor.
So an excellent question. We have not addressed this directly. I've noticed from my observations that if you really just treat a catheter with way, way too much therapy, then you will start to notice some visual changes. But that was at doses that were, again, thousands of times higher than what we're seeing here. As far as whether or not the biofilm would return, that's a bit more difficult because, like I talked about, you treat this catheter and you just rip all of the biofilm off of the wall without necessarily killing the bacteria unless you massively increase the dose, like I talked about. So you would probably have to continue treating the catheter every other day or so, or like one of our other students pointed out here, using it as a prophylactic measure, which I really think is the future of this technology.
Great, thank you.
Thank you.
All right, we have one more presentation. This one will be by Lily Ladner, who worked with Dr. Michelle Theus from the Department of Biomedical Science and Pathobiology, as well as Dr. Eric Marvin from the Department of Neurosurgery. Lily's mentors share that Lily has been, without a doubt, one of the most exceptional medical students to have gifted us with her talents. She has a strong passion for both research and patient care, which makes her stand out amongst her peers. Among several recognitions for her research, she was awarded a prestigious American Academy of Neurology Fellowship. She's been deeply involved in studying biomarkers for traumatic brain injury, connecting the science behind her studies to real-world clinical impact and has resulted in 3 peer-reviewed publications, with more to come. Beyond her research, Lily is the most delightful individual you could hope to meet, a dedicated team player, always stepping up to mentor others and contribute to the broader medical and scientific community. Now we're going to hear about vascular immune biomarkers for traumatic brain injury.
I have really big shoes to fill with that speech there, Dr. LeConte. Also, I know that I'm the last presenter, so I'm going to try to go in 2.5 times speed for all of you so you can get out of here. But today I'll be talking about some novel biomarkers in traumatic brain injury. I work in the lab of Dr. Michelle Theus in the Center for Neurotrauma and Dr. Eric Marvin in the Department of Neurosurgery. This is a project on TBI, which is a highly prevalent and debilitating condition affecting between 47 and 69 million people worldwide each year. When you zoom into the state of Virginia, it's the highest cause of injury-related death. Beyond mortality alone, TBI causes a variety of known deficits, including deficits in memory, attention, and executive functioning, to name a few. Despite these known deficits, there is no definitive prognostic biomarker for patients with brain injury. So this begs the question, can we discover a biomarker that predicts a TBI patient's long-term outcome? And why would this biomarker be useful? There are a variety of clinical implications for such a biomarker. First and foremost, this would allow for patients and their families to have a stronger sense of clarity as to how well the patient will do in the long term following their brain injury. Second, by identifying novel biomarkers and their associated pathways, we will be able to develop novel treatments that more specifically target each patient's individual pathophysiology. In my lab, we study biomarkers in this space that I find really fascinating called the vascular immune niche. So here we're looking at the cross-section of the vasculature that supplies blood to the brain with a specific focus on endothelial cells. Our biomarkers are called angiopoietins. You see here on the left-hand side, Ang1 promotes increased vascular stability. Ang2 does the opposite, promoting increased vascular instability and an influx of immune cells into the brain. In our lab, we have shown in a mouse model of brain injury that Ang2 is upregulated, while Ang1 is downregulated, but this has yet to be translated into the human population, hence the conception of this study. This is a prospective cohort study of TBI patients at Carilion Clinic. On average, patients were in their mid to late 20s, which is expected for the TBI population, and there was no difference in age between TBI and control samples. Serum was collected at 24, 48, and 72 hours. Protein expression was assessed via ELISA assays, and retrospective chart review was conducted to determine immune cell expression. Our outcomes were varied, but included the following: Glasgow Outcome Scale, Glasgow Coma Scale, need for surgical intervention, days in the ICU, and days on a ventilator. So this brings me to my results. Patients had a variety of mechanisms of injuries, with the most common, considering we're right next to IAD1, being motor vehicle collision, followed by fall. A variety of types of injuries as well were experienced by patients, as listed on this slide. And as far as interventions, about 17.1% of patients experienced neurosurgical intervention, while 11.4% of patients experienced external ventricular drain placement for intracranial pressure monitoring. In-hospital mortality was low at 5.7%. Average days in the ICU were around 10, and average days on the ventilator were around 9. So let's talk about these biomarkers, huh? Here we're looking at angiopoietins. On the left-hand side, we see Ang1 expression. On the right-hand side, we see Ang2. The control values are those red lines, and the TBI values are the blue lines. We see a significant reduction in Ang1 expression and a significant elevation in Ang2 expression, which suggests some level of vascular permeability or blood-brain barrier instability, and effectively translates our preclinical findings. The next question we wanted to ask was, how do these biomarkers correlate with long-term and in-hospital outcomes? So as far as surgical intervention, we found that not our biomarkers, but the neutrophil count and the leukocyte count were associated with risk of neurosurgical intervention. As far as in-hospital mortality, we found that the neutrophil count and the neutrophil to lymphocyte ratio were associated with increased risk of in-hospital mortality. Our biomarker, angiopoietin-2, and this index called the Systemic Immune Inflammation Index, which is highlighted on the bottom of the slide, were both associated with length of stay in the ICU. And the systemic immune inflammation index alone was associated with length of time on the ventilator. The next question we wanted to ask was, is there a subset of individuals who are more genetically susceptible towards increased TBI severity or towards more blood-brain barrier permeability? So to answer this question, we did something that should remind you of first year of medical school, and we looked at single nucleotide polymorphism, or SNP genotyping. And what that is it's a single base substitution at the level of the gene, in our case, encoding for the proteins associated with angiopoietins. What we found was that the SNP that we studied for the angiopoietin 1 protein was associated with a lower GCS at admission, suggestive of a higher TBI severity. So overall, we found that there is some level of vascular endothelial dysregulation in the TBI population, which confirms our preclinical findings. We also found that our biomarkers were associated with in-hospital, but not necessarily long-term outcomes. And finally, that there may be a subset of individuals who are genetically susceptible towards increased TBI severity. At this point, I would love to thank my wonderful team, including Dr. Michelle Theus in the Center for Neurotrauma, Dr. Eric Marvin, and all the lovely residents who woke me up at all hours of the night to consent TBI patients, the VTC and Carillion research staff, and of course, I would be remiss to not express my gratitude for the many mice and many subjects who participated in the creation of these data. At this point, I can take any questions.
Great talk, Lily. Any questions for Lily?
Love the presentation, Lily. I don't know if you can talk any more about how your findings relate to potential therapeutics and pharmacologic treatment, potentially for people who have experienced a TBI.
Yeah, so in our lab, we're studying a therapeutic called vasculitide. And if you look at one of my slides, vasculitide is essentially an angiopoietin 1 mimetic. So the idea being that if we're able to replicate the function of angiopoietin 1, and I didn't explain this in detail, but they kind of competitively antagonize the same receptor. So we're able to replicate Ang1, knock off Ang2 from that receptor when it's elevated. We might be able to kind of recapitulate a normal blood-brain barrier in human patients. We've shown in a mouse model of brain injury that there's improved outcomes, but it's not yet been translated into humans.
Awesome, thanks.
I have an online question for you from Tristan Talazzi. I got you. Very interesting research. Do you think these biomarkers would also differ in mild TBIs and TBIs without positive CT scans?
Yeah, I think that's a really good question. And that's generally where the TBI biomarker space is focused because patients who have brain injuries, when they're very mild, can present to the ED with negative CT scans. So the question is, can we define biomarkers that allow for us to understand, are these patients severe enough to be monitored in the hospital? Do they really have a TBI? And can a biomarker reflect that when their CT scan can't? This biomarker in particular has not been utilized in the mild CT negative TBI population, but I think it's a great future direction. There's actually a track TBI study that incorporates these biomarkers and some other vascular endothelial related biomarkers in the more moderate to severe population. And I'm hopeful that track TBI decides to pick this up for their CT negative population as well.
Hi, great talk. Thank you so much. I guess I'm curious about if you've studied other, I guess I'm curious how you decided the markers you chose to study. I know in trauma and sepsis and other of these things that can occur as a result of an MVA, you can get vascular dysfunction as a result of like a cytokine storm or maybe some other factors going on. So I guess I'm curious how you decided to pick your markers and how you're convinced that this is predictive of a TBI and maybe not something more systemic.
Yeah, it's a good question. And I think it's a a question that can be answered with a much larger patient population. If I were to redesign this study tomorrow and start med school over, which I absolutely do not want to do, I would probably have recruited a third arm of patients that were orthopedic injury patients with no TBIs, because we need, and that's what a lot of groups are starting to do nowadays, because we need that negative control where you're able to say, is it because of an injury, period, or is it because of an injury to the brain? And I think that studies like this, where we kind of hint at the idea that there might be vascular dysregulation, I totally agree with you that we might be reflecting someone's femur fracture. We might not be reflecting, the vascular dysregulation in their brain because of the brain injury. So it's definitely a great control group to be considering for future studies.
Thank you so much, Lily. All right, I see the intrepid research domain team coming in. They scrambled during this last oral presentation session to get all of these awards taken care of and printed out and tabulated. So thank you, faculty. Okay, thank you, Jessica. Thanks so much. So please hang out for a minute while we go through these awards that were voted on. Before I move to that, I do want to let you know that the students who presented today who earned letters of distinction from the class of 2025 will be recognized with a plaque. You can see it. We have a research domain wall downstairs, and we'll put some of your posters up and recognize you as long as those plaques are hanging on that wall. So thank you very much. Let's go through the faculty awards. So as you know, we had faculty looking through the poster presentations, and they were selecting several different categories of awards. So we have best poster presenter, best hypothesis-driven study design, and outstanding scientist physician. So the first one I'm going to read was the best poster presenter, the student who articulates their poster presentation with the utmost clarity. So I'm going to read the name, and if you can come down and receive your award. Sachi Jalakia. Now you're all happy you sat in the back, aren't you? All right, now recognizing the student whose project was voted by faculty, the project best formulated a clear research question based on a hypothesis. This goes to Murli Konathapalli. And the student who best integrates clinical medicine with scientific inquiry and research, bridging the gap between discoveries and direct patient care, our outstanding scientist physician is Ethan Nethery. Okay, the next set of awards were the ones that the students voted on. So students selected awards. The first one was best visual design. So best poster design and data being effectively showcased. This goes to Sarah Kramer.
All right, I know many of you could have qualified for this award. It is the most hurdles overcome. Student whose project required enormous perseverance. This award goes to Chloe Lassard. Most exciting discovery. So the most thrilling scientific breakthrough, Farwa Iqbal. Most promising preliminary data for an NIH grant goes to Lily Ladner. All right, our last student voted award is most likely to change clinical practice this year. This goes to Brian Hansen. So I just want to say a few quick thank yous. So first of all, I think first and foremost, it's our incredible team of faculty mentors and faculty evaluators who really help raise the standards of research here at VTCSOM. So both our faculty who are helping day to day, but also those who are sitting in and asking good questions and helping you design your studies. So thanks to all of the faculty who help make this work. The team from the Center for Biostatistics and Health Data Science, so Dr. Alex Hanlon's team. We have several of you here today, so thanks so much. We've got Ben Brewer here. I see Chris Grubb, Alicia Lozano, Missy Zhang, Emmanuel Nartley, and Rachel Silverman. So a huge round of applause to all of those working with you. The team who helps pull this symposium off and make our research domain run all the time. So Dr. Nikki Worthington, Director of Clinical Research Education, really running so much of what we do day to day, our course, and then all throughout year 2, year 3, year 4. So thanks so much, Nikki. Our communications team has been helping all during the lead up to this. So Corey Baps helping with our website. Ryan Anderson has been here taking lots of pictures. So thank you, Ryan, and making fabulous videos. Josh Myers, so very appreciative to our comms team. Thank you. Michael Long over here helping us make sure that we're streaming on YouTube, making sure those questions get answered, putting posters up in the middle of the session. So thanks so much, Michael. Appreciate your help. Setting up the poster room. So everything that has to go on before the symposium happens, we got to take down all the tables. We got to roll them into a different room. And I say we as if it were me. It is not me. So thanks so much to Alan and Jeff for helping out with that earlier today, as well as those who printed the posters. So from library, we had Robert Silva and Gerald Hamilton printed all of the posters, helped us organize them. So big thanks to all of those individuals. I always like to thank our school's leadership for the investment that they place in research domain, both in time and resources. This is a unique part of VTCSOM. So thanks to Dean Learman, Dr. Michael Friedlander, Dr. Jed Gonzalo for their support of what is a pretty substantial investment in research here at VTC. Jessica Flowers, Crystal Barnett, oh my word. This is tireless work on their part over months. This takes months of planning and lots of cajoling of me to respond to emails and make decisions. So I very much appreciate your cheerful attitudes, your hard work. Thank you. So it's true, your cheerful attitude. Crystal, you keep me happy. It's good. So thanks so much, Crystal and Jessica. Okay, this last one is hard for me. So you all know Kara Spivey. She is our VTCSOM clinical research coordinator, but she is much more than that, right? So that's her title, but really she's an educator. We just recently made her an instructor in the Department of Health Systems and Implementation Science. She's a problem solver. She truly is the most cheerful person I have ever met. She's creative. She's innovative, she's persistent in the most professional way you can possibly imagine. And her impact on our research mission here just really cannot be understated, Kara, for real. She is taking on a role at Carillion as a clinical project manager. So she will no longer be helping directly with our VTCSOM students. She will still be helping with the research mission at Carillion, but she won't be an integral part of our team anymore very soon. So I just wanted to make sure that we recognize her. You will be truly missed. You've really raised the expectations for what we can expect for somebody in this role, and you will be impossible to replace, but you've really helped us build a model for what it takes to bridge the two organizations and make research happen. So Kara, thanks so much. We're going to recognize you with an award for outstanding service to medical student research. So yes, this award. All right, thanks everyone.
So who will thank the thanker in chief? I will. Because although Dr. Laconte plays multiple roles in the medical school and she brings her heart and her soul to each one of them, I know that this one is it's such a treasure for us to have her as the person who's looking after your research education with the team and helping from the vision to all of the details in the weeds as well to make sure this is an outstanding aspect of your curriculum. So Dr. Laconte, please accept our gratitude together. Are we adjourned? We're adjourned. It did. I'm going to try to load it up now.